Okay, I think we can go ahead and get started now. We'd like to welcome everyone who are joining us tonight for this webinar. Dr. Kornbluth will be discussing COVID-19 vaccines, variants, and booster shots. I'm Dr. Lignani. I'll be moderating, answering questions, and compiling them to discuss at the end of the presentation. I would like to remind you that this will be recorded. So if you're catching part of it or have to step out during the presentation, this will be present on our website, the NYGA website, some point later next week. So you could refer to it again next week with that. With that being said, we're going to turn it over to Dr. Kornbluth, and we'll look forward to questions and answers at the end of the session.
Okay, great, Pete. This is actually, I was thinking about our fourth one of these we're doing. We did the first one back in November 2020 when we were just talking about what COVID is. We did one, what I call Erev Christmas, 2 nights before Christmas. The vaccine had just come out a week earlier, talking about the clinical trials, what we could expect. And then exactly about 3 weeks later, when we still had a different president in the office, it was January 16th, talking about what the first month looked like. And so over the months, I'm thinking, man, we're done with this. There's no more webinars coming up. And unfortunately, or fortunately in some senses, over the last week, we have some good news and some bad news. So let's get started. We're going to talk about vaccines, variants, and booster shots. And we've been getting countless calls about this for the last week. So where are we? And this is where we were back in a year and 5 months ago in April. This whole hump is unfortunately, tragically, was New York City, New Jersey, Connecticut. We sort of, quote, squashed the curve. Then the rest of the country got hit in July, basically. And as, frankly, Anthony Fauci, who I consider a national treasure, despite what some people are saying about him and a lot of politicizing, he said back in early December and mid-November, stay out of crowded family get-togethers because we want to see a bump after Thanksgiving. It's exactly what we saw here, and exactly after Hanukkah and Christmas is exactly what we saw here. And you remember what the nightmare was back in January. Unfortunately, in New York, we sort of didn't feel this quite the same way. We had herd immunity, probably in large part, but this was where the entire country was getting slammed. There were 3,000 people dying a day. And in fact, in New York City, we had about 800 people dying a day just in our city back in April. So we had a flavor of this, but this is where the whole country felt it. This is basically, as you'll see, sort of superimposed on this is when the vaccines started coming on, and Scott Gottlieb, who's another giant, former Mount Sinai resident, former FDA chairman, a great all-around guy who was sort of, many people thought he was a voice of doom, but he got it right the whole way. And last March, early March, we were saying, we're going to have to close down the country. People thought he was crazy. What he said in sort of mid-January, when we were all panicked that there's not enough vaccines, there wasn't enough distribution, and there wasn't, he says, right now we're suffering from an overwhelming abundance of demand. And I predict in a couple of months, March, April, we're going to have an overwhelming overwhelming demand in January, and we're going to have an overwhelming need for people to get vaccinated around April. And that's exactly what you saw here, a lot of fall off here. Vaccine hesitancy, I think we can sort of agree that people are still hesitant at this point after over 300 million doses in the United States, probably are not going to be satisfied with 300 million pieces of data so far. And we really need to talk to them about the risks they are posing to other people who are vaccinated. And this is going to come up again throughout the talk, and I'm not going to politicize it. I'm going to be basically sticking to what we know from epidemiology, from what we know just following the demographics and the incidences of these cases. And you all know, and this is one of the reasons we're meeting tonight on relatively short notice, is over the last 10 days or so, but basically since July 1st, we're having this, again, relative explosion of cases. Now, this is exponential explosion. It's not like we were here, but it is this massive increase in percentage of cases. But fortunately, we were starting off on a very low number, but that is starting to disappear. The numbers are peaking here, and as we'll see, a lot of that is due to Delta, which is basically enhancing the transmissibility. So why basically do we have this outburst of questions about about the boosters. Well, just exactly 1 week ago, the FDA said on Thursday night, they're going to give an emergency use authorization, EUA, and people still say, well, I don't want to take the Pfizer or Moderna or J&J vaccines because they're not fully approved. They just have an EUA from day one. Yes, that's true. And the FDA, frankly, probably should be pushing along a little quicker to give full approval. By now, there's enough patients out there for whom they have data. And some people are using that as an excuse. Well, the FDA hasn't given it full approval. Well, it's been there for 300 million people already. So last Thursday night, they said, we're going to give EUA, in other words, basically free up doses, and there's plenty doses. We're not suffering from not enough doses of either J&J or Moderna or Pfizer, but specifically for Pfizer or Moderna. They didn't give this approval for J&J, and that's not because J&J, it won't work, this booster concept. It's just they don't have enough data yet. So Moderna and Pfizer, also known, you'll hear them referred to as the mRNA viruses, vaccines. Again, Pfizer and Moderna, they said that we can give those folks who are immunocompromised, and the word I used actually in our email that we sent to everyone was immunosuppressed. Consider it interchangeable. In the IBD, in our world of immunosuppressive drugs, we use the term immunosuppressed. Same thing. And what their point was, we are suggesting it, not mandating it, for certain. And they left it sort of wide open in terms of the definition. We'll get into some of the specifics as they pertain to our patients, your family and friends, and hopefully you welcome them and feel free to share this afterwards. And for fully vaccinated individuals, do not need an additional dose right now. Now, whenever I start these, I say this is news as of now, August 19th. Had I done this on yesterday at 5 p.m., this might have been a different talk. But as you know, yesterday, President Biden said at September 20th, he wants to give everyone, immunocompromised or not, an opportunity to get the booster shot. And we'll talk about who might be first online for that. The FDA has to give approval for the non-immunocompromised patients. But right now, the FDA has given EUA. In other words, you can walk into the pharmacy and they can give it to you. And in fact, and I'll say this up front, you do not need a doctor's note or any medical notes. You just basically self-attest. You say, I am eligible based upon being immunocompromised and the features we'll talk about now. This applies to Pfizer and to Moderna, not yet J&J. J&J was already doing studies looking at a 2-dose vaccine regimen before this whole concept. That data should be ready by the end of the summer, and the FDA will probably rule on that sometime soon. So immunocompromised people. All of these slides, by the way, they might look beautiful, like I've done tens of hours of work. I can't take quite that much credit. This entire slide deck, except maybe a couple slides at the end, is available online. You just go put in, you don't need to go to all these long links down here. If you put in CDC, August 13th, boosters, they have the entire slide deck and a lot more. I've tried to condense it to really drive home the message we have here. They actually, if you're interested, have the whole full 4-hour presentation. And the most interesting parts are, frankly, when the experts on the committee known as ACIP, advisory committee, you'll hear that besides the CDC, advisory committee on immunization practices. It's a subcommittee of the CDC. When they start talking and asking questions, not really arguing, that's where, frankly, it's the most interesting. So they will say outright, well, we don't have real great definitions of what we think are the immunocompromised people. But this is where things looked like last Friday as of 3 p.m. Meetings start at 11 a.m., done by 3 p.m. So, and we'll get to what applies to most of our patients in a moment. Active or recent treatment for solid tumor and hematologic malignancies, receipt of solid organ or recent hematopoietic stem cell transplants, bone marrow transplants. And the FDA basically said patients who have solid organ transplants and treatment for it and comparable moderate to severe immunosuppressed. And the next day, the FDA was counting on the CDC to lay out additional detail. You see it here: severe primary immunodeficiency, those a number of congenital abnormalities, advanced or untreated HIV infection, that is pretty clearly defined, And here we talk about what might apply very much to our patients, particularly our patients with Crohn's and colitis. Active treatment with high-dose steroids, for the sake of the term that came up there was 20 milligrams or greater, but I think we would all say, gee, if you're on 10 milligrams, 15 milligrams, we want to get you off, as we'll see in a little while. Anyway, alkylating agents, we don't use those in inflammatory bowel disease. Anti-metabolites, by which we can consider 6-MP, azathioprine, and methotrexate, 3 drugs that we have thousands and thousands of patients on, particularly 6-MP and azathioprine. Tumor necrosis factor blockers. What are those? That's Remicade, and its biosimilars, Afsola, Inflectra, Humira, Cimzia, Simponi. They call those out outright as your immunocompromised, and other biologic agents that are immunosuppressive or immunomodulatory. That's a pretty broad category. And we'll talk about that more specifically. But in terms of our IBD patients, our patients with Crohn's and colitis, or other immunologic diseases, your friends and family might be listening or watching, where they'll say, gee, I have rheumatoid arthritis, I have psoriasis, I am on some of the same medications. Stelara. Stelara is used for psoriasis. Some of our drugs are used for rheumatoid arthritis. In fact, Stelara patients, put aside COVID, are not at increased risk of infections. Patients of ours on Entyvio are not at increased risk of infection, but you could lump them under immunosuppressive therapy that can be eligible. Strictly speaking, Xeljanz is not a, quote, biologic, but it is immunosuppressive. And in fact, as we'll see at the end of the talk, anti-TNFs, Stelara, Entyvio, Xeljanz, our patients on those drugs don't do worse if they get COVID. And in some cases, they are actually protective. Then other conditions, which for the most part, we're not seeing in our practices, but for which there's a lot of data. Asplenia is when you don't have a spleen, and chronic renal disease, for which actually there's a lot of data that this is being based on. So that is not enough, though. If you're immunocompromised, including those who receive an additional RNA dose, we're suggesting it. We don't have very much data at all in terms of how protective that third dose is. We really have no real-world experience in whether it blocks infections or breakthrough infections. What we do know is that it builds antibodies, okay? And that's going to be what we consider a correlate or a surrogate or a predictor of prevention. But it's really early on, and the FDA and CDC, I mean, we're literally just getting this data in. They have really a paucity of data, but they're trying to make the best guesses here. And you'll see, in terms of safety, go ahead with it. And we'll talk, I'm sure, about very many specific instances. But if you're immunocompromised, still got to wear a mask, still stay 6 feet away, wash your hands, avoid crowds, poorly ventilated indoor spaces until the coast is clear. I don't know when that's going to be. You say, gee, I'm immunocompromised, I've been vaccinated, am I safe to go outdoors? We don't know yet. Having said that, our patients, again, the drugs we talked about don't increase your risk, except for prednisone, of getting COVID or having bad outcomes. So we're not telling patients, you got to behave as if you've never gotten vaccinated. But we'll talk again about patients at a higher risk and about the boosters. If you're living with someone who's immunocompromised and sick and hasn't gotten the vaccine for whatever reason, or got the vaccine and has not made antibodies, and we'll talk about measuring antibodies or not in a few minutes, you need to protect them as well. So why are we talking about all of this? Why are we getting so excited, so upset? Because we're trying to avoid hospitalization. When you have hospitalizations, deaths follow 2 weeks later. Serious infections, 2 weeks later. Hospitalizations, 2 weeks later, ICU and death. That's what we're going to see. So here you see New York. This is last spring. Here's exactly what we saw back in November, December, January. Thankfully, it started to fall. Some of this is because we were more cautious. A lot of this is because we were vaccinated. And again, big fall. And as you saw, the cases went up, and now hospitalizations are going up. Let me say this at the outset. Breakthrough infections, what does that term mean? Breakthrough infections mean you got the full series of vaccines, in other words, 2 Moderna or 2 Pfizer or the single J&J, and you're 1 month out from completing it. That's sort of the definition of you completed your vaccination series. If you get COVID after that, that's where the term breakthrough vaccination means. You got vaccinated, you got the whole thing. It's a month later, now you got infected. People might say, unvaccinated people might be using that as a rationale to say, gee, you folks who got vaccinated, you're having breakthrough vaccinations anyway. What's the point of me taking this vaccine if there are breakthrough vaccinations? The reason is people who have breakthrough vaccinations are rarely sick. Patients in the hospital now with COVID are almost all, 99% of patients who are sick enough with COVID to be in the hospital are unvaccinated. Serious COVID now is a disease of unvaccinated. We're going to see more and more cases of breakthrough because we're getting hundreds of millions of people treated, more people vaccinated, just by number, you're going to have more patients with breakthrough infections. By and large, they have been very mild, maybe even asymptomatic. So that is the take-home message here. Don't sort of point your finger at the data. Breakthrough cases, they're happening in the vaccinated. They're not getting sick for the most part. It is now COVID in the hospitals, a disease of the unvaccinated. By far, the most important public health measure now that we should continue to talk about is not booster shots, even for the immunocompromised. It's vaccinating those who are never vaccinated. Delta has arisen, as we'll see, basically because there's too large a pool of people who are still susceptible. How many vaccines have been given? And again, there was a very good podcast, I think maybe on the New York Times podcast, Wall Street Journal. They interviewed, there was an advertising executive that was recruited to put together an ad campaign in favor of vaccines. This was before the Super Bowl and the inauguration. He's the guy who got Trump and Bush, Clinton, who else is alive? Bush, Clinton, and Obama. And they stood there side by side, three presidents, two Democrats, one Republican, all talking about the importance of vaccination. That was his idea. He said, let's get them together. Let's give a unified message. He also made the point, when you're speaking to those people who are vaccine hesitant, you have to, and I'm maybe violating that concept right now, you have to speak to them with respect, and you have to respect their hesitancy. And I'm sounding a little agitated because of what we're seeing going on now, and you have to respect their decisions. So we should do that when we're talking to our patients, when we're talking to our loved ones, but you have to be able to speak factually with them. And people who don't frankly believe in facts or science, you can't convince them generally with facts or science. And what we're seeing now, a bump in vaccination is frankly because people are being told they can't keep their jobs if they don't get vaccinated. In France, the day the Tour de France finished, the president said, if you're not vaccinated, you put masks back on, you can't go back into movies, you can't go back into restaurants. And there were massive protests. Within the week, over 1 million new people were vaccinated. So there are societal measures. But again, we still have way too large a pool of people who have not been vaccinated. How large? Probably about 50% of the people in this country have not completed vaccination series. Fortunately, those who are the most vulnerable, people over the age of 65, 80% of them have been vaccinated. Kids, and this is just kids who have been approved for Pfizer, 12 to 18 years old, 60%. I'm not going to get into the whole issues of kids going to school and whether they need to be vaccinated, whether they should be wearing masks. Greater than 18 years of age, 61%. Why is this number low? Well, there's a lot of college kids, a lot of young people who basically say, well, I'm looking at the data, I believe in the data. People my age who get COVID don't tend to get sick, hospitalized, or die. And that is overwhelmingly true. So it's hard to argue with that. What they can do very easily is transmit readily to their parents and their grandparents. That's the greatest risk for the young people who aren't getting vaccinated. What drugs been used? If you're considering, let me speak with a little more respect, is what vaccines have been used? Well, Pfizer now in 90 million people, 90 million. These are fully vaccinated, 90 million people. Moderna, 63 million people fully vaccinated. J&J lags a lot, 13 million people. We'll talk about the potential side effects that you heard about, particularly J&J. First, they actually stopped its dispensing it for about a week. There was this very rare clotting disorder, specifically in women between the ages of 18 and 50. Turns out it's about 1 in 150,000. You'll see the death rate from COVID of people walking down the street unvaccinated is higher than that. There's been myocarditis in young men. There's been Guillain-Barré, about 1 in 200,000. These things happen in the general population as well. It's far more likely you're going to get severely ill, hospitalized, or die than those kind of numbers. Okay, so how many patients? Slide's a little bit older, also from the CDC. This is when they were about 140 million who had completed a 2-dose vaccine. And this is a couple of weeks ago, less than 1% had received a booster dose. 12 million, again, a little bit lower numbers, about a couple of weeks old this slide. Less than 1% had gone and gotten a COVID vaccine. How'd they do it? Most of those were probably people who were immunocompromised, immunosuppressed. They said, I know there's not much data. My doctor even told me maybe it's a good idea. Maybe they checked my antibodies or not. I want to get a booster vaccine. There is, as you know, a lot of vaccines still laying around with people coming in for boosters. Even if they open up the doors on September 20th, I don't think we're going to have a shortage of vaccines. I would think that J&J, specifically Pfizer and Moderna, have been cranking out vaccines. This has become extraordinarily profitable industry. Okay, this is, this parallels. This is not the same slide I showed you. This is parallels what's happened with the vaccination on top of, you could superimpose this on top of the hospitalizations and deaths. And this is what happened, obviously, where we had no vaccines in the beginning of December. So you started seeing here, this who's getting vaccinated here, healthcare workers and people in long-term care facilities. This is when everybody was driving hours and hours. I remember on January 16th, I said, if you live in New York, I just went online 10 minutes before I started the webinar. If you live in New York City, the next place you could get is Plattsburgh. 4-hour drive. I said, you know what? If you want it, get into a car. It's 8-hour round trip. It's probably worth getting. Now we have an overabundance of vials. And as you know, we're throwing vials away because people weren't going to get it. This is fortunately as more and more people are convinced it's a good idea. And that's as you saw in the prior slide, this is when hospitalizations, infections started to fall. And as you'll see in a moment, this is where we saw just now, this is where COVID is rising again. Hospitalizations are rising again. And that's probably in large part because this is flattened out. There's still a lot of people. Half of the country have not been vaccinated. So what is considered, when do we think about, what are the issues in terms of, should we be vaccinating our patients? I'm trying to clean up the screen a little bit for you. So what are the questions in front of the CDC when they had to decide this 1 week ago, literally almost a week ago? Is it effective? You see the abbreviation VE, vaccine effectiveness. Are the people who got it early on, i.e. December were the very first ones, long-term care health facility residents, healthcare workers, then after that, teachers, first responders, people working front-facing in groceries, public transportation, people who really struggled and truly were the heroes that whole time. They were getting it. Now they are 8 months out. So with time, is that benefit waning? And we'll go over some of that information. The short answer is yes. Is the vaccine efficacy for the vaccines, and again, we're for the most part talking about Moderna and Pfizer, is it reduced if you have Delta? And does the data, in other words, effectiveness, different for different groups of people, for the elderly, for immunocompromised? Benefits and harms. This is, I don't think people are hesitant about taking the vaccine because they don't think it's effective. Obviously, I think we all would agree that the people aren't taking the vaccine, it's because they're still concerned about safety. Immunogenic, that's a fancy word to say, do you make antibodies to the vaccine? So let me speak for a few minutes about antibodies. Antibodies is what we hope to make when you get a vaccine. You get the vaccine, Moderna or Pfizer, it's a part of the COVID vaccine. You don't get COVID, of the COVID virus. You don't get COVID. This is one of the myths, conspiracy theories that are propagated. You don't get COVID by injecting the vaccine. The vaccine is designed to make antibodies against one specific component of the real virus, the spike protein. So your body makes spike protein, which does not cause disease. Now the body has antibodies against this invader, the spike protein, which does not cause illness. Now a coronavirus comes into your body, a real virus, you're infected. It has spike proteins. You have made antibodies to spike proteins. Your antibodies attack the spike proteins on the real virus, and you kill the virus. And you reduce symptoms, you reduce disease, you reduce severe disease, you reduce hospitalization, and you reduce death because you've made antibodies to a component of the coronavirus. That's the word immunogenic, make antibodies. And that's why we measure antibodies in some patients. We measure antibodies to the spike protein in response to the vaccine you got. So the question is, are we giving booster doses? Will it reduce incidence of cases, hospitalization, and death? And that information we don't have if we're just starting to give the booster doses. All we could say, because it's easy to measure, we could give you the booster doses, do you make antibodies? And we're hoping that the people who make antibodies are protected. Makes perfect sense. Do booster doses improve vaccine effectiveness against Delta? That's a big question, because as you'll see in a moment, what we're struggling with, this country is now a disease is invaded by Delta. More likely, what happens? Why are we talking about immunocompromised patients before we'll talk about September 20th and all comers getting the booster shots? Why? Because immunocompromised people that fulfilled all those criteria, some more than others, someone who's 20 years old, has been on, say, Stelara for a year and a half, hasn't batted an eye, has never been sick a day in his life, that person is not likely to get sick if they get reinfected. Breakthrough infections, though, do happen in the sick immunocompromised people. Most of the hospitalized breakthrough cases were in immunocompromised people, and most of those, in fact, were not vaccinated. We do know that in all comers, if you monitor these people with immunosuppression, immunocompromised for any of those reasons, vaccine effectiveness is a lot less than people who are not immunocompromised. So chronic medical conditions, we got to put everything in context. We're hearing in our practice and doctors everywhere, and I'm sure you're thinking you might fit into one of those categories of having one of those medications, one of those other illnesses perhaps. Should you rush out and get it? Well, the answer is if you're otherwise healthy, you're on one of those drugs, for, let's say, IBD, which don't increase your risk of getting COVID, don't increase your risk of getting sick. I don't think it's urgent, emergent that you got to run out and get it. When should you get it? I would say go get it, especially if it's a number of months since you've been vaccinated, because as we know, as you'll see, the antibodies wane with time. And as you lose your antibodies, presumably, you're more likely to get infected. Ask your doctor, but the bottom line is we're going to tell you that. If you are on high doses of prednisone, you're ill from a number of different scenarios, we're going to say go and get it. If we know you don't have antibodies, because we happen to have measured them, we'll have pleaded with you to get the booster dose. And anyone who's listening, please, we beg you on behalf of ourselves, our families, everyone, your loved ones, people who are immunocompromised. If you haven't been vaccinated, you are in the situation, you are in the position to help the immunocompromised the most. The CDC recommended that you should get the one booster shot of the one you got. If you have Moderna, get Moderna. If you got Pfizer, get Pfizer. But if you can't, no big deal, get the other one if you're really stuck and you can't find the one you originally got. We spoke about a minute ago, we look at the whole picture. How sick are you overall? Are you losing weight? Are you big doses of prednisone? Are you clinically unstable from a number of other morbidities? So we put this all into consideration. If you're young, 20-year-old, you're perfectly healthy, you haven't had any infections from any of your immunosuppressive meds, we're not as concerned as if you're 70 years old, you're 40 milligrams of prednisone, you're on a high dose of an anti-TNF. Those people we would push a lot harder. Now, serologic testing and cellular immune testing, what does that mean? Serologic testing is a fancy word to say measuring antibodies to the spike. They're commercially available. Cellular, and that reflects just because you'll hear a lot about this thrown around by doctors on the TV shows. Well, you don't have B cell protection, but you have T cell protection, or you have a cellular immune function. Two major arms of our immune system protect us against infection. One is B cells, which are the cells that make antibodies. Antibodies are easy to measure. We send patients to LabCorp every day of the week. We can measure antibodies to the spike protein. T cells produce what's called, T cell immunity. They're the cells that produce things like the various cytokines, TNF, interleukin 12, interleukin 23, a variety, dozens of cytokines that are part of our immune system to fight infection. And it turns out maybe T cell function, the T cell immunity might even be in the long term more important to protect us against COVID than antibodies. We don't know that. And in fact, I think, frankly, we've been saying for months, well, don't worry, if you don't have antibodies, you still have T cell function. We don't know that. The problem is you can't measure T cell function in any commercial way. It's research lab level. So we'd like to think that if you don't have B cell function, at least you have T cell function. We really don't know that. And the drugs we use, for instance, like the anti-TNFs, that's interfering far more with T cell function. But again, if you hear the words serologic testing, that's the antibody testing, and the cellular immune testing, there's no way to do that. Now, the CDC was very clear, and this is, again, these are all CDC slides. We do not recommend checking for antibodies. And everybody who's listening, who's been a patient of mine on any immunosuppressant for months now, I've been saying, you know what? Let's add an antibody to your blood test we're doing now. And I've said that all along. I'm certainly not going to change now. And this is what I say. I say, we have no idea. There's one particular antibody level we check because there's at least some data for it called the SARS semi-quantitative IgG spike antibody done by LabCorp. And if you're my patients, I literally on your lab requisition put the specific test number so that people in LabCorp know what to draw because there's a number of them. Some of them just say positive or negative. The one we've been ordering gives you a level, a number. The CDC has said repeatedly, and I say every time I ask a patient to get this drawn, I say, I don't know what level is protective. I don't know if a level of 10 is protective or you need to have greater than 500, or the upper limit is, the lab will say, greater than 2,500. So I don't know what to make of those numbers. And I say that before we even draw the labs. What I do say is if you got no antibody, then you're not protected. And if over the months, and that's, I've been saying to people for months now, the reason we're getting is so over time, we might want to follow this to see what your antibody levels are doing. And we're now sort of, my patients who are stable on the biologic drugs, I see them every 3 to 4 months, let's say. And so we're now at that 3 or 4 month period where we're starting to see people whose antibody levels are falling. And unfortunately, we've had now out of probably 100 patients, I've measured this, I have 5 patients who did not make antibodies. Fortunately, none of them have gotten sick with COVID, but they're clearly not out of the woods. And really, those folks, by definition, they're all on immunosuppression, and they're being very cautious. And I've been telling them for a couple of months now, find a way to get the booster shots. Now it's easy. You walk in, whether you have antibodies or not. And the official recommendation is don't waste time getting antibodies. We don't know what to make of them. We don't know what level is protected, and we don't want to gum up the works. We don't want to make this so much more complicated. We're not the first place to do this in the United States since last Friday morning. We're sort of behind. France has done this since April for the severely immunocompromised. Israel started doing it about 6 weeks ago and are now gradually adding over the age of 60, and maybe even by now, everybody in the country, I'm not sure. Whoops. England has been doing it again for immunocompromised people, and a couple of weeks ago, Germany for people who are immunocompromised. Israel, I know, was doing people over the age of 60, and I think, I'm not sure, are already opening it up for everybody of any age. So when we talk about boosters, there's 2 concepts. Most of it applies to what's in this box. But if you haven't been vaccinated yet, and you have one of those immunocompromised situations, the recommendation now is you get the sort of booster dose built in. So if you get Moderna or Pfizer, instead of 2 doses, you get a 3rd dose. Data's not out there for J&J. Frankly, I would say for my patients, because we have so much more Moderna and Pfizer, get a Moderna and Pfizer. And if you're immunocompromised and I've finally, hopefully convinced you about the value and the safety of the vaccines, take the 2 doses and 28 days later, get a 3rd dose. Most of our patients that we're talking to, fortunately, most of the people we're seeing have been vaccinated. So when we're talking about booster doses, it refers to giving a dose after you've completed your set of vaccines, either with Pfizer 3 weeks apart and then Moderna 28 days apart. At what point after that? So the CDC, again, not based on data, but basically the smartest guys in the room dealing with vaccines, dealing with virology, vaccinology, epidemiology, they arbitrarily said, if you want to take a booster shot, wait 28 days and go and get it. You don't have to wait 90 days, 120 days. Is 28 days a little too early if you're perfectly well? Well, maybe, but there's a lot of doses out there. We don't anticipate severe side effects in the 3rd dose when we didn't see them in the first 2 doses. So again, that's the concept of a booster dose. Now, does it work? So we're not sort of elated with our outcomes in people who are immunosuppressed, who did not make antibodies after their first 2 doses, Pfizer or Moderna, and then get the 3rd vaccine. They're not out of the woods. If you look at people, seronegative means you didn't make antibodies. So it was looked at, we don't have an IBD population that's looked at it so far in this fashion. The 5 largest series are patients who had either solid organ transplants or on hemodialysis. And it first got broke out a couple months ago in the New York Times when the Hopkins transplant population said that patients on the immunosuppressants for transplant, roughly, I think about 20% of patients made antibodies. Our IBD patients, I want you to know, it is probably all from cyclosporin, tacrolimus, mycophenolate, because we're not seeing that with Remicade. And we could talk about the data we have in terms of making antibodies to Remicade, in which case I could tell you over 80% of people or more will make antibodies. The transplant literature say, gee, I'm immunosuppressed with IBD meds. They're immunosuppressed with transplant meds. They are different medications. But if you are in those groups and you are seronegative, meaning after 2 doses, you didn't make antibodies, after your 3rd dose, only about half of people are making antibodies. So this is not, a walk in the park. If you're not making antibodies because you're immunosuppressed, and maybe because you have other comorbidities on board, doesn't guarantee you the 3rd dose will do it. But what I do personally, based on 0 data, I would get a 4th dose. 0 data. Is there a risk? The bottom line is we're not seeing tens of thousands of people yet. As we saw, less than 1% of the people who have been vaccinated have gotten booster shots. But what we've seen so far is that people are getting, these are not side effects. These are what we call reactogenicity. These are the sort of side effects we all get within a day or 2 of the injection. And they're far more common than not. Pain at the site, some redness, some swelling, fever, fatigue, headache, chills, vomiting, diarrhea, and we don't have real data. People ask me, can this trigger my IBD? We haven't really seen that. Soreness, joint pain. And in terms of how serious they are, nobody's really gotten critically ill with this. Most of them are mild. Some people do feel really laid out. But I have to say, in hundreds of patients who have got vaccinated, any number of which who found that they didn't feel great afterwards, I have never found a patient who tells me it lasted more than 48 hours. So I tell people in general, if you haven't gotten vaccinated, or now if you're getting your booster, why don't you do it on a Thursday night or a Friday when you don't have plans for the weekend? Because you can feel pretty crummy. And maybe it's more likely if you're going for a booster shot when your immune system has already made some antibodies. So you might get a reaction that's not considered ill adverse event of the booster shot. So what do we know? The best possible evidence. We have evidence that the RNA vaccines, Pfizer, Moderna, in immunocompromised people enhances antibody response. And again, the 50% data was in sick patients with transplants or tumors, chemotherapy, not the patients we necessarily see with the drugs we use. We don't have data yet in terms of actually preventing infection after the 3rd dose. In the small studies so far, we're not seeing side effects. The reactogenicity, again, those are the reactions you get, was similar to the prior doses. And yes, I'm not brushing this under the carpet, rare but serious side effects. But again, 1 in 140,000 for the blood clotting disorder seen in women with J&J. Myocarditis, rare. Anaphylaxis in people with no history of anaphylaxis, rare. Guillain-Barré, rare. Far more likely to get COVID and serious COVID than any of those serious side effects. And again, no data so far in adolescents. So you're listening for your 15-year-old, your 12-year-old who might be on Remicade, et cetera. I certainly can't comment on that. We have some great pediatric gastroenterologists at Sinai. That's a question to pose to them. Again, just to briefly mention pregnancy, the CDC back in January, we were sort of tenuous. Now they came out and said there's no reason for pregnant women not to get the vaccine. And they made a proactive statement. If you're pregnant, if you're lactating, if you're thinking of getting pregnant, the vaccine is something that you should do. Take-home message in bold letters: vaccination recommended for all patients ages 12 years and older. Between 12 and 18, it's just the Pfizer vaccine. 18, anybody could get Pfizer or Moderna or J&J. Pregnant, lactating, trying to get pregnant, or might become pregnant in the future, we have no reason to think they are not safe. So overall, people in the CDC said, well, let's get public information. People in front of these meetings are asked to submit comments. Most people are immunocompromised. Well, sort of people who contact the CDC are the ones you'd imagine want to get vaccinated. There are concerns for the immunocompromised and in everyone still about not, again, the effectiveness, but side effects. And in general, the demographics have been very, very well defined and consistently since January among all patient populations, all risk factors. Younger age, kids, college kids, young adults, they think they're immortal. And in fact, they don't get real sick real frequently, but they can affect others very effectively. Women, racial and ethnic minorities, less formal education. And as you all know, and this is not politicizing it, certain states, there are vaccination rates of 30%. And there are almost inevitably people who are in Republican states. And you know, the Republican governors in certain states are adamantly against masking in kids in schools, adamantly not pushing for vaccination. This has become, again, extraordinarily politicized. But again, education, the outcomes of people who get the vaccine, the protection, the safety profile, and the outcomes of getting sick is the same whether you're a Republican, a Democrat, or a communist. Keep that in mind. And again, people who are sort of writing into the CDC, by definition, most of them who are going to write to the CDC are people who are interested in getting it. It's our responsibility as professionals to talk to our immunocompromised patients. And again, put it into context. If you're a healthy 20-year-old and you've done great, never had an infection, and you're safe, you're not running around in college bars, drinking and screaming with everybody else without a mask who hasn't been vaccinated, but you have been cautious. We're not rushing folks like that to run out and get the vaccine tomorrow, although you are eligible. And again, you don't need a note from us. And basically all of the medical societies, whether it's the transplant societies, the infectious disease societies, the IBD societies, we're all recommending that people get vaccinated, number one, and we're coming out in favor of vaccinating with booster shots for those people who are immunocompromised. Overall, the vote from the CDC, they have no vested interest in these votes. The outcome, the benefit is large. The undesirable anticipated effects, small. Again, we already went through these two slides. So variants, this is what's captured the news and the world's attention right now. So let me familiarize you with the terminology so you know what things have been called before, what they're called now. So frankly, the WHO has said we don't want to call it the British variant or the South African variant, or the P1 is more Brazilian or Peruvian or India. I mean, this was rampant in India. This is why India had the overwhelming mortality rate in large part because they had no access to our vaccines. And now they're getting names Alpha, Beta, Gamma, Delta. This is the area of concern. When Alpha was here, we called it the British variant. Everything is sort of, we're trying to lose their names, their names of their country of origin, and they're getting a Greek letter. So Delta is the one, as you'll see in a moment, that is in this country and it's almost all the cases in this country, at least the ones that we are doing sequencing on. The real problem, very, very, very efficient transmission, even in vaccinated people. Okay, but again, those vaccinated people, even though they can transmit, they probably do it less frequently because they probably have less virus on board than people who get infected with Delta not vaccinated. Maybe it's less likely to respond to vaccines. We're not sure of that yet. Reduced neutralization by vaccine sera. What does that mean? When you hear a vaccine is effective against a newer variant, it's not because they did clinical studies in 30,000 patients the way they did with the original studies. What they do is they take serum from people who've gotten that particular vaccine, and in a test tube, they say if it neutralizes the virus. Okay, that's neutralization by vaccine serum. People are vaccinated, you take their serum out, you see what it does to the virus in a test tube. We don't have enough data on looking at these patients long term. We have some. This is what's happened over the months. This is where we are now. Delta, and it even has a couple of subsets, is now exactly what Fauci predicted a few months ago. Let's get everyone vaccinated. We're going to have variants. And 2 months ago, when people were barely hearing about Delta, he said in the summer, this is going to be all we see. And it's exactly of everything we see. Alpha, which was big, this is the British variant, was big here in the spring. It's sort of dissipated a lot, has been replaced. Why? Because Delta is far more likely to be transmitted. And look at this, the British variant Alpha is now tiny, what we call the ancestral strain, which is what we were originally infected with in 2020 and early 2021. That's barely not present anymore. It's almost gone. It's been replaced by Delta. That's why we're talking about variants. Antibody neutralization in the lab, that's how we're proving for the most part so far that a vaccine is effective. We need to have vaccine effectiveness in real clinical studies. And it's important to remember that you might see data and it might be alarming, and it should be a stimulant maybe to go get your booster, but that a vaccine is losing its effectiveness. You have to ask yourself, is it losing its effectiveness against infection? And I'll talk about the definition of that in a moment. Disease, meaning you get symptomatic. Severe disease, which has various definitions. Think of it, high fevers, very short of breath, hospitalization, and death. So you might see that the effectiveness has gone down to 70% or 40%. That's generally against asymptomatic disease, where you're screening people and you're seeing people are infected but not sick. They are still, fortunately, highly effective, our original Pfizer and Moderna, against severe illness, hospitalization, and death. So you shouldn't be looking at the data and say, gee, the data has gone down to 50% effectiveness. It might be 50% effective, no longer 95% effective against getting COVID. But again, it's still very highly effective against getting hospitalized and sick. And you'll see that in a moment. This is the problem. We're starting to see waning immunity. And we're going to look at some very specific, very, very brand new data from Israel in a minute. This is what happens against severe illness. And you'll see the Pfizer vaccine at 6 months, it will block fewer infections. But in terms of serious illness, we're still at 97%. Okay? Infection, preventing infection in all comers, 96%, 90%, 84%. But again, this is only 4 to 6 months. We're not getting data on 6 to 8 months. And the number here is falling. It's going to be a steady fall. But in terms of severe illness, still 97%. And that probably is going to happen to go down as well. Why are we worried about Delta? At least twice as contagious. It might lead to more serious illness if you get it. But even if it doesn't give more severe illness, let's say it gives the same frequency of illness, by the virtue of the fact that 10 times as many people might get infected, you're going to have that many more people hospitalized. Still, the greatest risk of transmission is among unvaccinated people. And vaccinated people can get it. They can have breakthrough infections, almost always mild, almost never hospitalized, and they are infectious for a shorter period of time. This is the data that most people will get alarmed by if they see that, for instance, the Delta in the triangle, in terms of blocking infection in Israel, Alpha was originally what we were studying originally. Actually, this is the British variant when they were getting most of the country vaccinated. It was effective 90% of the time in terms of blocking infection. Well, now the Delta you're blocking, and Israel has Pfizer exclusively, I think, or at least the vast majority, only about 40% of infections are being blocked. And only 40% of patients are you blocking with symptoms. But if you look at severe disease with Delta and Pfizer, you still get 90% effectiveness of blocking severe disease, i.e. hospitalization and death. So although we are seeing a decline in protection, a decline in protection against Delta, fortunately, we are still seeing for hospitalization and death. Qatar also has an enormously effective vaccination rate. That's with Moderna. Again, blocking hospitalization and death, whether it's in Qatar, whether it's in Israel, this is all Delta, whether it's Pfizer in Canada, we're still very effective getting vaccinated to block death from Delta. So get vaccinated will also protect against this new horrible variant. This is very brand new. It's not even fully published. Israel has been at the forefront of this data because they were at the very outset the most aggressive about getting their patients vaccinated. They had an abundance of, no shortage of Pfizer vaccine. They promised Pfizer that in return, they will rigorously collect the data. And Israel has four basically different sort of silos of socialized public-private medicine, and the people are followed from birth up, and the data is very well collected. Israel was able to publish on 600,000 people shortly after they started their vaccination programs, and their vaccine effectiveness was almost identical to the clinical trials, about 95%. Israel is keeping very good records. They have very centralized medical records for the entire country. They are now seeing, and this is why Biden probably got on the air yesterday and September 20th, and we know this, and this is going to be de rigueur, this is what we're going to do for everyone. Double an increased risk for breakthrough infections for people vaccinated in January through April compared to after April, right? So if you're vaccinated, say 4 to 8 months earlier, you're twice as likely to have a breakthrough infection. Breakthrough meaning, again, the term means you got vaccinated, now you got a vaccine. Infection rate, this is another study, a small study, 33,000 patients, 2% vaccination, 2% breakthrough if you were vaccinated more than 5 months ago in the first wave of vaccination. If you were vaccinated within the last 5 months, your breakthrough rate was less. What is this telling us? You're making antibodies, the antibodies are starting to decline, you're more likely to get infected. It's not surprising from a biologic point of view. This is what we're interested in. Again, moderate impact may be in terms of the effectiveness, but again, the vaccines are effective against blocking severe disease. So currently authorized vaccine offer protection against the known variants. You can still get breakthrough infections, but again, you're vaccinated, you're not likely to get sick. Yes, you can still infect others, but less likely to do so and less likely to do it for a prolonged period. CDC is following real world effectiveness, not just antibodies, but seeing if the booster shots are going to help people. And they're going to obviously keep a close eye on the effectiveness in variants. When will boosters be recommended for everyone? I had no idea if I had put this together last Friday night. Now, yesterday, we're talking about, the CDC actually put this out. Will we start doing it? And it was totally speculative, and they said, we'll get back to you. And it's going to be based on that concept. Your antibodies start to wane. So who's going to have the lowest antibodies first? The people who got their vaccines in December, January, and February. The people who are highest risk then are by definition the people who have the lowest antibodies now. So they're I'm sure they'll roll it out to long-term care facilities, healthcare professionals first, because by definition, they're the highest risk of either getting sick or transmitting to others. And they're the ones with the lowest antibody titers, presumably right now. Now, we have lots of patients, I'm sure, on the line who have inflammatory bowel disease. We see so much of that here in our practice at New York Gastro through all our offices. And there's a lot of concerns, obviously, because so many of our patients are on immunosuppressants. Some baseline information. This is no different. Ryan Ungaro, Mike Kappelman, Erica Brenner from Mount Sinai, University of North Carolina. Ryan is a superstar. He's one of our fellows now. He's a young faculty member. They put together what's called, and I encourage you to go look at it because it's meant for the public to peruse. And Ryan has written a number of papers on it already. Over 6,300 patients in this registry. And just look up secure, SECURE, secure IBD registry. It'll pop up. They'll explain what the registry is. There's a tab that says our data. It goes through about 66 countries of reported cases, 6,300 patients. And when you have that many patients, you get a lot of data about what are the risk factors for bad outcomes. And basically they are, not surprising and not unlike other disease states, over the age of 65, 2 or more serious comorbidities, and prednisone. You're 8 times more likely to end up in an ICU or die if you're on prednisone. It doesn't mean 8%, but 8 times more likely than people are not on prednisone, 20 milligrams or more. It makes us even all the more aggressive about getting people off prednisone. What we found wasn't apparent after the first 500 patients, but when you get thousands of patients, you get more and more data that becomes finer and finer. 6-17-azathioprine also seem to increase the likelihood of a bad outcome. What is clear, anti-TNFs do not. Ustekinumab, Stelara does not. Entyvio does not. Xeljanz does not. And some of those are actually being studied in trials to treat COVID, because COVID, the patients who get real sick, it's not really that the virus has gone rampant. What's happened is the virus has triggered what we call cytokine storm. Cytokines are these inflammatory chemicals, some of which our drugs block. You block TNF, your Crohn's and colitis gets better. You block TNF in the lungs, your pneumonias might get better. So those drugs we try emphatically not to stop. So don't be worried about those drugs. Now, the newest registry, and Millie Long has started this registry. She's a superstar from the University of North Carolina, and they actually invite patients. It's through the CCFA. You could go through, here's the website, just go to IBD Partners, put in prevent, it'll show up. And they are actually still recruiting people, I believe. This is from July, 3,400 patients with inflammatory bowel disease, and they're monitoring their antibody status, okay? Because presumably antibodies are predictive of who is more likely to get an infection. And we want to know, do your medications our medications that we're prescribing, do they inhibit your ability to make antibodies? So here's her data so far. And she actually, I think, has a grant, and patients can get paid up to, I think, $130 to participate in this by giving blood several times. And everyone who's heard about it wants to participate. The patients are, like most folks with Crohn's and colitis, between the ages of, say, 20 and 50 or even older. Not too many kids in this series. What do the patients in this series look like? And we'll get to the punchline in a minute. How many don't make antibodies? But again, most of the people registering here, well, the vast majority are less than 20 years, 20 to 30 years. What do the patients who are in the registry look like? Whenever you look at a registry, especially when it's a voluntary registry, you have to think about who has the time, who's motivated to go on and report. Same thing with secure, right? If I reported my first 100 patients who had COVID and IBD to the registry, now they're up to 6,000 patients. I don't think reporting a patient, unless there's something particularly interesting about that patient, is going to make a difference. So right now, if you look at newer cases in secure, you're probably going to see sicker patients being entered. So you always have to say, the patients in that registry, do they look like me? Do they have mild, moderate, or severe disease? Well, here it's really a very equal mix down the middle. People here are basically, most of them, or half of them, rare symptoms, the others, active disease. These are the medications the patients have been on, the whole mix. Oral steroids are the ones that worry us. You could tell by the mix of the drugs that people are on, that people who are enrolling, by and large, tend to be the people who are most motivated to be followed because they know they're on immunosuppressive drugs. Remicade and Humira and Stelara are the 3 most frequently used drugs. Fortunately, this isn't much, but these are the patients who will make the least amount of antibodies or not at all. Less than 1 means they're not present. These are the various titers. For those of you who've been getting the LabCorp assays, and I tell you your level is 400 or 1,000 or 11, this was not the same test. Here, basically, they looked at between 1 and 11, 11 and 20, 20 to 30, and more than 30. not in the range of 10 to 2,500 in the assay we use. You can't compare assays, and the CDC made it very clear, do not try and use assays. Don't necessarily use this to guide treatment. But what is the take-home message is 4% of patients did not make antibodies at all. And those were the patients typically who are on prednisone. That's what we're seeing in our population. Also, either prednisone or multiple immunosuppressives. So to sum up, because Peter yells at me because I go on too long, what are the messages? And not just for IBD, but everything we've talked about, COVID-19 infections, vaccines, antibodies, take-home messages for what you can do. This is particularly perhaps for IBD people, but everybody, getting you off steroids, 6-MPA if possible, vaccinate, vaccinate, vaccinate. And I apologize if I was not unduly respectful for those of you who are still not vaccinated. If you are in one of the categories, I think you should get the vaccine booster. If you've had antibodies and you're not sick and you've always been well, I don't think you have to rush out tomorrow morning and worry about not getting it. And continue sustained protective COVID hygiene. And again, my plea, I get emotional here. Please, your friends, your neighbors, your loved ones, we all are in this together. This is something I never thought in January we'd be meeting on a beautiful summer evening having to still talk about this. So with that, I'll thank you. I've gone on probably way too long by Peter's reckoning. I have to deal with Peter tomorrow and the rest of my life, but Peter's going to open it up to moderate some questions.
Okay, thank you, Dr. Kornbluth. That was fantastic. As usual, our very informed and intelligent patient population has presented a number of really good questions that we're going to get to right now. So one of the common things that people ask is, how do I know if the vaccine is working for me? Does it matter if I didn't have a reaction to the dose? If I didn't feel achy or feverish or crummy, I just felt like it was anything else and went about my life. Does it mean it didn't work? Does it mean I need to be worried? How do you answer those patients?
I answer them, there's no reason to think it won't work. You know, a lot of the messaging has changed over the months, in part to reassure people and encourage people to get vaccine. So at the beginning, we were saying, gee, if you get one of these reactions, you have reactogenicity, it's a good thing. It means you made lots of antibodies. Your immune system got all jacked up. So the people who didn't get any reactions were saying, gee, man, does that mean I didn't make antibodies, that I lost out? The answer is no. We don't have data that if you had a reaction, you're more likely to be protected than those who do not. Did we collect that sort of data? No. Again, part of it is all part of the messaging. If you got those nasty reactions, that's probably a good thing. If you didn't have a reaction, I wouldn't say that's a bad thing.
So a number of questions about the timing of vaccines related not only to their immunosuppressant medications, namely the injectable or infusion medicines, but also as we're approaching flu season and people are getting their flu vaccines in relation to other vaccinations for routine health maintenance, like shingles vaccine, flu vaccine, pneumonia vaccine, et cetera. What do you recommend people to, in terms of timing from the COVID vaccine in conjunction with the other vaccines that they may be scheduled for?
All right, so to break it down, first of all, the CDC said it should be 28 days or more after the second dose of whatever vaccine you're on. Again, they left J&J alone for now. My hunch is that they will come along the same way. So it's at least 28 days. Initially, we said, don't get a vaccine, don't get the COVID vaccine within 2 weeks of any vaccine. When it came out in the winter, a lot of people getting the flu shots were juggling their vaccines. It wasn't because we thought necessarily they'd interact with each other. It was because if you had a reaction to one, we wouldn't know what it was from. And then you got to weigh the risks and benefits. Right now in August, I don't think that we are particularly concerned about the flu. If you are at higher risk for shingles, certainly if you've just been exposed to someone with it, or you're on one of our medications that increases the risk of shingles, in particular Xeljanz or now Zeposia, I would get the shingles vaccine if you don't have some burning reason to get the booster, meaning you're not sick, you don't have zero antibodies. Then I'd get the booster. So you have to weigh risks and benefits. Again, there's no rushing emergency if you're well on one of these immunosuppressed medicines. Should you get it? I'll say yes. People asked me all last week, would you want to get it over the weekend? You can take your time. I think it's still going to be available. Frankly, probably get it in the next week or two, because September 20th, the floodgates might open and there might be a paucity of the vaccine, but I don't think so.
Now, if I'm due for my Stelara, Humira, Remicade, et cetera, tomorrow, and I have an appointment for the vaccine on Sunday, is that a problem? Should I delay my dose? Should I be off my immunosuppressant before the vaccine to help the vaccine work better?
So that's a great question. And when the IOIBD, which is the International Organization for IBD, came out with their recommendations, this is back in January, they basically said, don't try and time it. The best time to get the vaccine is the day it becomes available to you. And the best vaccine to get is the one you could get your hands on. Now there's sort of a variety of vaccines. There's less of a pressing need to get the vaccine tomorrow because it might disappear. The problem, and we're still not telling patients time it to when you get your immunosuppressive drug. It would make sense that you would say, gee, if I'm about to get my Stelara or my Remicade, why don't I take the vaccine today and then I could put off the Remicade? Well, frankly, you take probably a couple of weeks to make the antibody to the vaccine. And then you're going to have Remicade on board in a big dose anyway. So it's hard to time exactly when you're expecting your body to make the antibodies and exactly when the Remicade is going to be at its peak dose. So the short answer is we don't know. There is one recommendation by the CDC that if you are going to sort of electively start immunotherapy, start some kind of immunosuppression, try and get your booster shot 2 weeks before, because we like to think that the first 2 weeks, most people will make the antibody. Again, the bigger concern is you start delaying your immunosuppressants. God forbid you're going to flare. Think about steroids. So they're going to be things you need to call your doctor and make an appointment about, because there's a lot of moving parts for some people. But that's a great question, and we don't have a definitive answer.
So to follow up on that, because you said back about 7 or 8 months ago, the best vaccine to get was the one you could get. Now we are lucky to be able to choose which vaccine we can get. And for people who've received the Pfizer vaccine and have seen the data suggesting that the Moderna vaccine may be better against Delta, should people who've gotten Pfizer instead get Moderna for their booster? And if not, why not?
So I don't think that the question is, the answer is I don't think there's that much compelling data. The data in terms of antibodies is not the same as real world long-term effectiveness against Delta breakthroughs. I have no objection to that reasoning. I'm not sure that is going to shake out to be a real difference between Pfizer and Moderna. I have been telling people, unless you have absolutely no way in the world to get Pfizer and Moderna, I don't prefer J&J as my first choice. We have a paper that again, Ryan and two superstar medical students, Emily Spira and Danielle Gangine, have just literally tonight are going to polish off this paper, hot off the press, not even public yet. Patients who have IBD, this is from the Secure Registry, and get vaccinated, there are breakthrough infections. They tend to be more with the vaccines in the J&J class, meaning DNA vaccines from China and AstraZeneca, rather than the RNA, Moderna, or Pfizer. In fact, J&J, to be fair, none of the patients got it in that registry. But it seems to be there's a signal, and I could tell you also maybe, I'm not 100% sure that maybe from that PREVENT data, that the mRNA vaccines are more effective in our IBD patients than J&J. And in general, we have seen that in terms of initial protection, the numbers were higher with Moderna and Pfizer than with J&J. So there seems to be some signal that the RNA vaccines are better than Janssen and Janssen. Having said that, we're also maybe seeing that in our IBD patients.
So in short, the answer is there's no reason to think that getting Moderna after Pfizer is any better than getting an additional Pfizer.
What we know now. And again, the FDA said, the CDC, actually the FDA too said, if you can't get the same one, get the other. But they didn't say, go get the J&J. All right, that's important. We have no data about that. Although there is data from England and Germany, heterologous versus homogeneous, meaning if you got AstraZeneca, which is a DNA vaccine, did you do better if you got a second DNA vaccine, second AstraZeneca, or went over to an RNA that's called heterologous? Those people actually, there was a tendency to do better. That's not saying they got RNA first, then AstraZeneca, that they did better. So we're still learning a lot about this.
Excellent. So another question, and this has been a factor for a number of my patients who in the past 6 to 8 weeks have tested positive, most of them being asymptomatic, but some of them having some mild symptoms and a few having more significant symptoms. Does it matter if you have recently tested positive for COVID? With the implication being, if you tested positive for COVID in the past month or two, then you are almost certainly exposed to Delta. Does that alter the timing or the need for a booster vaccine?
I don't want to swear on a stack of Bibles that the CDC addressed boosters after breakthroughs. I can tell you that there's probably no real data on boosters after breakthrough. Having said that, just to extrapolate what we do know is put aside boosters, but primary vaccination. If you had COVID, we all know we're still telling people go and get vaccinated. So should we extend that to say, well, you have COVID, again, active COVID, still go get a booster? Frankly, in the absence of data, I would say I'd wait the famous, in this case, 28 days. For the primary infection, it was generally 90 days, and I'd get a booster based on no data. And again, don't believe anybody who says something with 100 degrees of certainty here. This is just what I think will probably evolve to be the recommendation.
Good. Now, in addition to that, there are people who had COVID either early last year when it was sweeping through New York or more recently and haven't had the vaccine. And this comes down to, in part, conversations that we have with family members, friends, relatives, strangers on the subway, et cetera. They say, I've had COVID. Why do I need to get the vaccine? I had it last year. I don't need to get it this year because I'm protected. Isn't getting sick with the virus better than getting the vaccine?
Isn't getting sick with the virus better than getting the vaccine?
Correct. Meaning that they think that having had COVID makes them more protected against an infection. Therefore, they don't need the vaccine.
So there's a single study that I just found yesterday that hasn't been published that, in fact, people who had infections last year versus vaccinations now tend to have lower antibodies, which might just be purely a function that they're 16 months away from their active infection, whereas people who had vaccines are within the last few months. So I don't think, and again, we don't have data that there's exact correlation between the amount of antibodies you have and your risk of infection. But I think it stands to reason. And again, we've been telling people from day one, all the recommendations, you have COVID, you should still get vaccinated if you're 90 days out. Now, most of the people in New York who were sick were almost all March and April, slight blip in August, September, almost all March and April. So we're talking about basically 17, 18 months. Those antibodies in large part, I've measured in some patients who told me the same thing. I had it in March and April. I don't want the vaccine. The answer is antibody levels in people who are vaccinated are higher, and we're starting to see reinfection rates.
Right. Now, a few questions about monoclonal antibody therapies if you have COVID. And the questions primarily broke into two major categories. One, if you have IBD and are on a biologic, does that mean that you cannot get the monoclonal antibody therapy? And two, if you get COVID and are immunosuppressed, does that mean you should get monoclonal antibodies immediately? Or are there certain criteria that you look for where the monoclonal antibody therapy would be recommended?
So I cannot tell you that there are firm recommendations, but from what I understand, and if someone's listening and I'm getting it wrong, please dial in. There's no contraindication of getting monoclonal antibody treatment. There's from Lilly, there's from Regeneron. They've gotten a lot of news, particularly Regeneron. The fact that you're not on immunosuppressant should not prevent you from getting monoclonal antibodies. And don't think about it too long. Monoclonal antibodies have their best benefit within the first 24, 48 hours, 72 hours of when you're starting to get symptoms. So that's when you should be thinking about it. That's when you should find the place that will infuse it for you. So from my knowledge, being on biologics is absolutely not a reason to avoid monoclonal antibodies, which in many cases will keep people out of the hospital.
Correct. And I think,
Peter, you're freezing up.
an exposure to some,
You're frozen. I wish you like this in the office sometimes.
indication to get a monoclonal antibody infusion. The majority of people, if you're asymptomatic, you will remain asymptomatic like that. If you're starting to get symptoms, that's a different story. And I think most people would recommend only getting the monoclonal antibodies if you're a transplant patient, if you're severely immunosuppressed, or if you're beginning to have symptoms around that time. The last question, and this is with the what Dr. Kornbluth was saying at the end about discussing with people. Why do I need to get a vaccine when there is no long-term data telling me that there won't be any problems from it? How do I know that the vaccine is not going to cause problems with me, to cause cancer, or to have my unborn children get autism or have birth defects? How can I be sure about that? And why is it safer to get the vaccine than to just get the virus? This is actually a conversation a lot of patients have and are frustrated because they have them with people who don't want to get a vaccine, and their struggle with how to answer that and how to counter that argument in a calm and rational way. So what advice would you give to those people?
Okay, so here I will revert to what I learned on that podcast, to be respectful and not to answer questions in a way to scare people. To me, one of the people I love to listen to, and I'm always searching him on YouTube, is Paul Offit, Offitt. He's fun to listen to, lots of information. You don't have to be a scientist to listen to him. He's at University of Pennsylvania. He's a pediatrician, practices. He helped develop the rotavirus, and his career has been about vaccinology, developing vaccines, convincing people to vaccinate. A lot of what I say here comes words out of his mouth, so I learn a lot. You can learn a lot from him. The point he makes is, since Jenner in the 1700s designed or discovered smallpox vaccines from cowpox, every vaccine that's emerged in those 200 plus years, there hasn't been a single vaccine that has delayed side effects. The complications we see, whatever they are, and there have been serious complications. Polio gave people polio vaccine. We saw when the swine flu came around in the 70s, there were vaccines and people got sick. They happen within weeks to months. So if we are in the first few weeks or months of a vaccine, then I think that is a very, very credible concern. It has not been in the history of vaccinology in over 200 years diseases that have occurred late. The concerns about autism is really a tragedy, because every rigid, extraordinarily large database that has looked at autism has found that it is not a result of childhood vaccination. The study was done by basically a total beyond discredited. He was thrown out of, he lost his medical license. I believe his name is Wakefield. He did this. He's become a prominent anti-vaccinologist. This was a scandalous paper he wrote. It was withdrawn. There is zero scientific credibility about the autism. And we know just a year and a half ago, we had a massive measles, mumps, and measles outbreak, and they affected communities in which we have many of our patients. And it's a live vaccine. So our adults who came running and said, I need to get my measles vaccine because I have an outbreak in my community by children of anti-vaxxer parents. We said, well, it's unfortunate because I know you need the vaccine because there's so much measles in your community and you are immunosuppressed, but the measles vaccine is a live vaccine. So you're going to be exposed potentially to kids with measles. And measles could be a fatal disease in adults, but you can't get the vaccine because there are people who are preventing their children from getting vaccine. Again, I'm starting to sound agitated, like I'm trying to scare people, but you have to look at the facts. It's over 200 years of vaccines. There's not been evidence of long-term complications beginning months after a vaccine was started. And now again, people say, well, I want to see the first 2 million people, 5 million people. We have over 300 million doses, 160 million people in this country who have been vaccinated. We are not seeing any degree of frequent side effects. The likelihood that you will get COVID, no matter how young you are, and get sick is far greater than these very rare side effects.
I agree. And I think that's an important thing that hopefully we can all discuss with people that we know who are hesitant, and hopefully we can convince their thinking with that. I think we've touched on the majority of the questions. I think this is time to call it a night. We'd like to thank everybody for participating by sending in questions and by listening to this. Hopefully, this will be the last that we'll have to do with this as things go away. But as things change, we will obviously be putting more of these out in the future. Again, if there's part of this that you missed, this will be on the website likely next week. I hope everybody has a good night. And Dr. Kornbluth, thank you again for this very, very informative and well done presentation. Thank you.
Thanks, everyone. Again, to my moms out there, if you didn't manage to log in, I love you. You'll be able to get it online next week. So thanks, everyone. Hope everyone's well.